Thank you, everyone, for letting me share my perspectives as a patient and surgeon who's had bariatric surgery and how I try to avoid and manage weight gain. I have nothing to disclose, except as the title says, I'm a bariatric surgeon and bariatric patient. These are mostly my opinions, but they have been based on almost 20 years as a bariatric surgeon, as well as my personal experience and review of the literature. And recently, I got my ABOM board certification. My personal weight loss journey, like many of our patients, actually began in adolescence, but I didn't actually officially become obese till my general surgery residency. And by the time I finished residency and fellowship, my BMI was actually 36. And so several years after residency and fellowship, I elected to have a lap band. I actually didn't find it to be a very successful weight loss tool, but it definitely helped me plateau. And so after about 2004, my very rapid weight gain kind of slowed down, and I stopped gaining. And in many ways, it helped me to be the tool that I wanted it to be. And I successfully became a mother in 2008 and had a healthy pregnancy with very minimal weight gain and gave birth to a very healthy daughter, which is really what I wanted my tool to do for me. But unfortunately, after that, I continued to gradually gain weight. And by 2012, I was a BMI of 40, and I elected to undergo a lap band explant and conversion to a laparoscopic sleeve gastrectomy. And this was really the tool I needed. Over about the next year to 14 months, my BMI went down to 32, and I definitely became healthier, happier, more active, and really could enjoy the time with my family. I also did go on to have body contouring surgery, which I found very helpful in my journey. However, as I was approaching my 50th birthday last year, I started to notice that things got much more difficult. My weight was starting to creep up, and my BMI was back up to 34. So I did start on a GLP-1 agonist, and since then I've lost about 30 pounds, and my BMI is now 29. You have gotten an excellent talk by Dr. Sudan about picking the correct operation, and I 100% agree that picking the right first initial operation is essential. But there's very little out there about picking the right reoperation for lap band patients, and I think I have a unique perspective on that I wanted to share. Much of the lap band literature describes the lap band as purely restrictive. In fact, much of it states that the lap band does nothing to decrease appetite. And it repeatedly says that if you inject saline, you tighten the opening and you decrease emptying. But I have to tell you from my personal experience, I did not find this to be true. When my lap band was properly adjusted, I was not hungry. It absolutely killed my appetite and made me not hungry and made it much easier to stick to small portions. And I know that that's a fact because every time I ever had to have my band deflated, I became ravenously hungry. So when it came time to pick what I should get revised to, and again, these are very much my personal observations, having counseled hundreds of people on what to do with their band, as well as my personal observations. I've found that band patients tend to fall into really two categories. For some people, including myself, the band really helps them decrease their hunger. It causes them to eat slowly. It reminds them to chew their food well and take 20 minutes to 30 minutes to eat a meal and eat decreased portions. These are patients who rarely throw up unless they really have a misadventure and aren't paying attention. On the other hand, there are other band patients where they use this as a highly restrictive tool. They want the maximal amount of fluid in their band at any time, and they really eat every meal until the band forces them to not take one more bite. And these are patients who throw up regularly. What I've seen in my experience is this first cohort of patients will succeed no matter which operation you give them. On the other hand, the second group of patients really only succeed if you give them a restrictive operation like a gastric bypass. If you give them a sleeve, they will be disappointed. They will not feel restriction with a sleeve. And they will come back 6-9 months later saying they have no restriction and they will have had poor weight loss as a result of it. Oftentimes when I'm describing this to patients, I describe the sleeve like a yield sign that's reminding patients to do the right thing, and the bypass as a stop sign that will stop you often from taking another bite. So this is very much an informed consent conversation. How strong a tool does the patient need? Do they need a yield sign or they need a stop sign? And every patient is going to be different. Now, how do you maintain weight loss once you have found that lowest point? And again, I'm prefacing this by saying this is once you've hit the maintenance phase. Early on, patients need to eat in a way that you have created a diet and structured plan with your dietitian to help them lose weight. But once they're in the maintenance phase, I really strongly feel patients should only eat if they're hungry. We need to stop telling people to eat breakfast if they're not hungry. There's no evidence that adults need breakfast. Now, they should break their fast when they get hungry and not wait until a specific time to have lunch. Because if they do that, they're going to end up overly hungry. They're going to overeat at lunch. They're going to eat too fast. They're going to eat too much. They should eat when they're hungry, and they need to stop eating when they're not hungry anymore. We need to stop telling people to eat 3 meals and 2 snacks if they're not hungry. We also need to tell them that they need to stop when they're not hungry or satisfied with their meals, instead of eating until they're full. I often think of this as a progression. We all start a meal and we're hungry. We eat a few bites and we're not hungry anymore. We eat a few more bites and we're satisfied with food with the eat. That's our happy place. And that's really when we should stop eating. But most of us eat a few more bites because we just want to enjoy that happy feeling for a little while longer. And you end up full. But if you keep eating, trying to get back to your happy place, instead of going back to your happy place, you end up over full. And then you end up Thanksgiving full. And too many of our patients do that. They miss their satisfied happy place and they just keep eating and eating, hoping to get back to the happy place. And instead they end up over full. And that's how you stretch things out. So we need to teach them to eat when they're hungry and stop when they're either not hungry or satisfied, but don't aim for full. Next, and this is moving more towards the literature, is they need to get plenty of sleep. We've all seen curves like this that show that the average number of hours you sleep in a night correlates to BMI. But the question is why? And it actually comes down, and there's a great study that came out of Stanford many years ago, that if you get less sleep in a night, your ghrelin actually goes up and your leptin comes down, which means your hunger hormone is going up and your satiety hormone is coming down. And what's that going to make you do? It's going to make you eat more. And certainly as a bariatric patient, I find that. As a surgeon, I find that. The nights I get a good night's sleep, I am much less hungry and I am much more compliant with what I should do the next day. The nights I am post-call or I've been up operating all night or I get a crummy night's sleep for whatever reason, I am absolutely more hungry the next day. I am much less likely to listen to my body and stop when I'm in my happy place because my leptin levels are down and I don't find myself in that happy place. There are many other GI hormones that are affected by bariatric surgery, and these are just a couple of them. And we've seen lots of studies that talk about the impact various bariatric operations have had. But GLP-1 is the one I wanted to focus on because, as I mentioned in the introduction, I have gone on a GLP-1 agonist, and I really think that these medications have been a game changer for both myself and many of my patients that I've been able to use them on. But there's science behind it. This wasn't a medication that I picked at random, and I don't pick it at random for my patients. And here's why. We all know that various studies have shown the GLP-1 goes up with most of the operations, but it's not necessarily a durable effect. In fact, in this study that was just published last year, the dotted line is the GLP level over time in both bypass and sleeve patients at the time they had their surgery. The black line is their GLP levels 3 months after surgery. The blue line is 6 months after surgery. And I'm sorry, the red line is 6 months after surgery, and the blue line is a year after surgery. So what you're actually seeing is their GLP goes up right after surgery. Well, for those of you who are not very familiar with it, GLP is a hormone that we all make that helps our insulin work better. So in response to a food meal, when your insulin goes up, your GLP should go up. And if your insulin is working the way it should, it helps you not be as hungry, it helps you get full, it helps you feel satisfied, it helps you not crave sweets, and it helps you not crave carbohydrates. Well, that's what we want from our bariatric patients. We love for the GLP-1 to go up. And that's part of the reason these operations work. But it doesn't last over time, as this shows. The longer out they are from surgery, the more the GLP response is coming back to baseline. So if we can give them a medicine such as liraglutide or semaglutide, which is giving them GLP agonist back, it's going to restore them to that feeling that's very similar to what they had after surgery. And in fact, that's what several of my bariatric patients compare it to. They call it a pouch reset. They say that when they are on these medicines, they feel like they did 3 to 6 months after surgery. They get full on a small amount of food. They have great satiety. The food sticks with them. They don't crave carbohydrates anymore. Forget about the pouch reset diets. That's what these medications are doing for them. And that's certainly what I found. As I mentioned, I went on this and I've lost 30 pounds in the last year. And I've really found it to be the tool I need as an adjunct to my surgery tool to help maintain my weight and keep it where I need to be. I know Dr. Corrigan is giving you another talk on using weight loss medications, and I'm sure she's going to give you even more details of other options. As I said, GLP-1 agonists really restore that sensation of being just like after surgery. It decreases hunger, and you get full on much less food, and it decreases those cravings. Now, you can't have a talk about weight loss without covering exercise. There are people who actually prescribe exercise to their patients, but outside of the context of bariatric surgery, there is no evidence that prescribing exercise actually results in weight loss. These studies actually haven't really been done in our bariatric surgery patients, but we do know that exercise has been shown to be important in weight maintenance, even if it's not important in weight loss. But I'll be honest with you, I don't exercise to lose weight or even necessarily to maintain my weight. I had bariatric surgery to be a healthier person. And exercise makes me a healthier person, even if it has no impact on my weight. It improves my cardiovascular health, my lipid health, my bone health, and preserves muscle mass. And I think that's an important thing we have to stress to our patients. Weight is only one metric on the scale. It's only one metric of success with bariatric surgery. And it is not going to be the be all and end all to make us healthy. We have to look at the entire picture of how we make and help our patients get healthier. And we need to encourage exercise, even if it doesn't have any impact at all on their weight, because it will make them healthier. And our goal should be a healthier patient. And there are lots of health benefits of exercise, even irrespective of weight. So that's the messages I wanted to share with you. I'm so sorry we're doing this virtually because I would love to be able to answer your questions live. Please feel free to email me or contact me if you have any questions. And I can't wait till we can all see each other face to face again. Have a great day.